Imagine signing up for like a permanent life-altering surgery on one of the most sensitive parts of your body.
Right, which is obviously a massive decision.
Yeah, a huge deal. You do the consultation, you pay thousands of dollars, and you go under the knife. But imagine doing all of that when a recent clinical pilot study shows there is a 40% chance you can't even correctly name the specific anatomical structure the surgeon is cutting.
I mean, it sounds incredibly reckless when you frame it that way.
Doesn't it?
It does, because you just naturally assume anyone undergoing surgery understands, the basic blueprint of their own body. But the data from the cosmetic gynecology sector shows this massive disconnect between what patients actually know about their anatomy and the skyrocketing demand for these procedures.
And the growth is just staggering. I mean, between 2012 and 2017 alone, we saw labia reduction surgeries increase by over 200%.
Over 200%. That's a huge spike.
Yeah. What used to be this completely taboo behind closed doors conversation is now, a highly marketed menu of both surgical and non-surgical aesthetic options.
Exactly. And the clinical guidelines, the National Health Service protocols, even the ethical opinions from the Royal College of Obstetricians and Gynecologists, the RCOG, they are all kind of scrambling to keep up.
Because the industry is moving way faster than the regulatory framework.
Way faster.
Which is exactly why we are pulling all those sources together for you today. We're doing a deep dive to answer a very specific, pretty complex question that just keeps popping up in this space.
Right, the big combination question.
Yes. Can you combine non-surgical injectables like labial fillers and the O-shot with a traditional surgical procedure like a labiaplasty?
Well, to even evaluate if a combination like that makes medical sense, you kind of have to look at what the foundational surgery is actually trying to achieve first.
A baseline, right.
Yeah, the baseline. When patients come in for labiaplasty, the overwhelming majority are looking for a reduction of the labia minora, the inner lips. The surgical intent there is just to remove tissue that protrudes or, causes physical discomfort.
But reading through the surgical techniques in our sources, it's not just some one-size-fits-all amputation.
No, not at all.
Like the most common approach listed is the trim or the edge excision. So functionally, the surgeon is just taking a scalpel and cutting away the dark or uneven outer edge of the tissue and then sewing that raw edge back up.
Right. It is the most straightforward method. I mean, it removes the excess length very effectively.
But there's a catch.
There is. The biological trade-off is that the patient loses the natural original edge of their anatomy. You are basically creating an entirely new surgically constructed margin.
So it's a bit like taking a pair of scissors to the bottom of a skirt to make it shorter.
That's a good way to look at it.
You completely lose the factory hemline.
Right. And if we follow that tailoring logic, the main alternative is the wedge technique.
Okay, how does that one work?
Well, instead of cutting straight across the bottom edge, the surgeon removes a V-shaped section, like a wedge, from the central portion of the tissue.
Oh, so that they take a dart out of the middle of the fabric, fold the two remaining sides together, and sew it up.
Exactly. The overall length gets shorter, but that original natural edge stays completely intact.
That makes a lot of sense. You keep the original hemline.
Yeah, and it preserves the natural aesthetic, which a lot of patients really prefer. But surgery in this area carries really high neurological stakes.
Because of all the nerve endings.
Exactly. The tissue is densely packed with them, which is why we are seeing the emergence of this third option, the de-epithelialization technique.
De-epithelialization. That's a mouthful.
It is. But rather than cutting a full thickness wedge or trimming the edge off completely, the surgeon uses a laser or a scalpel to strip away only the outermost layer of skin, the epithelium.
Wait, how does just skimming the surface actually reduce the size of anything?
It's all about how you close it. When you remove that top layer and suture those raw surfaces together, you are essentially folding the tissue in on itself.
Oh, I see.
Yeah, you reduce its surface area and its bulk. The critical mechanism here is depth. By staying shallow, the surgeon avoids severing the deeper vascular and nerve networks.
So you reduce the physical footprint of the tissue while, theoretically, preserving maximum sensation.
The goal, yeah.
But not everyone wants to preserve the natural look.
Yeah.
Because the sources detail this highly controversial method popularized by a Dr. Alan Sod out in California.
Right, the Barbie look.
Yeah, it's colloquially referred to as the Barbie labiaplasty, which just sounds extreme.
Well, the surgical goal with that technique is basically total invisibility. The surgeon aggressively removes as much of the labia minora as anatomically possible.
Wow.
And they often combine it with a clitoral hood reduction to remove the excess skin covering the clitoris. The objective is a completely smooth, flush aesthetic.
It sounds incredibly extreme. I mean, why go through something that drastic? I think the immediate assumption people make is that this is purely driven by superficial cosmetic insecurity or, toxic internet standards.
And the psychological influence of marketing is undeniably a factor there. But painting every single patient as merely insecure kind of ignores a very harsh physical reality for a lot of women.
The functional side of things.
Yeah, let's look at the functional data. Imagine a patient who is an avid cyclist, right, or a marathon runner. Excess tissue in that area isn't just an aesthetic annoyance for them.
It creates severe mechanical friction.
Exactly. Chafing, pulling, actual micro tears in the skin from the repetitive motion of high-impact sports.
Which sounds agonizing.
It is. And that leads to a secondary issue, which is hygiene and infection. Tightly folded, excess tissue can trap moisture and bacteria.
Oh, right.
So many of these patients are requesting surgery because they are battling chronic urinary tract infections or recurring yeast infections. For them, slicing away that tissue is purely a path to physical comfort.
Okay, so a scalpel is great for removing a physical obstruction. But what if a patient's problem isn't too much tissue, but rather a loss of volume, like a loss of function due to aging or childbirth?
Right. Cutting things away isn't going to help with that at all.
Exactly. So that requires a complete shift in the clinical strategy. You put down the scalpel and you look to the syringe.
Yes, the non-surgical route.
And the cosmetic clinic data details two main pathways for restoring volume, specifically to the outer hair-bearing tissue, the labia majora. We have to talk about the terminology here, though, because clinics are marketing something called labia puffing.
Yeah, it does sound a bit like a cheap spa treatment.
It really does. But it involves injecting hyaluronic acid fillers like Deserial or Nuyuvia Rose directly into the tissue.
The branding is certainly casual, but the chemistry is very specific. These are cross-link hyaluronic acid gels, and they're formulated specifically to hold water and add structural volume to mucosal tissue.
But the clinical literature says those HA fillers only last, 12 to 18 months before your body's enzymes just dissolve them entirely.
That's right, they aren't permanent.
So if the filler just vanishes in a year, aren't clinics essentially selling an expensive temporary subscription model for your body? Like, why not just do a fat transfer, which the sources note is a permanent surgical option?
Well, you're comparing a purely mechanical filler to a biological integration there. A fat transfer, where a surgeon uses microliposuction to harvest fat from your abdomen, purifies it, and injects it, that is a permanent structural change.
Right.
But the reason some patients opt for the temporary HA fillers first is the surgical threshold.
The downtime.
Exactly. Fat transfer requires anesthesia, liposuction recovery, and downtime for the grafts to take. HA fillers can literally be done in a chair with some numbing cream.
I do see the appeal of zero downtime.
Yeah.
But earlier you mentioned the fat transfer does something that standard fillers just can't do, and it involves something called the stromal vascular fraction.
Oh, yeah.
What does that actually mean for the patient?
That is the most crucial difference between the two approaches. Fat isn't just inert padding.
Okay.
The stromal vascular fraction is this component within harvested fat that is incredibly rich in adult stem cells.
Oh, wow.
Yeah, so when you transfer that fat into a new area, you aren't just adding physical bulk. Those stem cells integrate, they begin establishing a new blood supply.
So they are actually changing the tissue.
They actually regenerate and improve the cellular health of the surrounding skin permanently.
So the fat is alive. It's actively upgrading the neighborhood it gets moved to.
That is a perfect way to put it. And that concept of biological regeneration is the entire foundation for the most talked about injectable in this sector.
The O shot.
Yes, the orgasm shot, which is trademarked by Dr. Charles Runels.
And unlike the HA fillers or the fat transfer, the O shot doesn't use synthetic acid or harvested fat. It uses PRP platelet-rich plasma, and the raw material comes straight out of your own arm.
It does. The clinical protocol starts with just a standard blood draw. That blood is placed in an FDA-approved centrifuge, spinning at high speeds to separate the red blood cells from the plasma and the platelets.
You're basically isolating your body's own first responders.
Exactly.
But how does injecting a concentrated serum of your own blood actually solve issues like severe pain during sex or, stress urinary incontinence?
Well, when those concentrated platelets are injected into the upper vaginal wall and the clitoral area, they immediately begin releasing at least 7 different growth factors.
Okay.
This isn't just plumping the tissue like a standard filler. It's commanding the local stem cells to initiate a massive healing cascade. The body is effectively tricked into thinking there is an injury that needs repairing right there.
So it's forcing the body to build new infrastructure?
Yes. The growth factors stimulate the production of new collagen, the formation of new blood vessels, which means increased sensitivity and blood flow, and the generation of new nerve endings.
That's wild.
So for a patient experiencing dyspareunia, painful sex, or vaginal dryness, the PRP physically rejuvenates the mucosal lining. And for stress incontinence, that new collagen thickens the tissue supporting the urethra.
Which helps prevent those accidental bladder leaks when you laugh or sneeze.
Exactly.
But even with all those benefits, the effects of the O-shot still cap out around 14 to 18 months, right?
They do, but look at what actually happens during those 18 months. A hyaluronic acid filler just sits in the tissue, taking up space until it dissolves.
Right.
PRP fundamentally changes the cellular landscape.
Yeah.
It is actively regenerating the tissue's function, not just its appearance.
Which brings us back to our core question for this deep dive. We have the surgical side, the scalpel cutting away the excess,
Yeah.
and we have the injectable side, the fillers, fat, and PRP regenerating volume and function. Can a patient safely undergo all of these at the exact same time?
The clinical protocols confirm that not only is it possible, it is frequently the standard of care for achieving a really comprehensive result. Yeah, because anatomical changes rarely happen in isolation.
That makes sense.
Hmm.
I mean, if a patient is dealing with the after effects of childbirth, the physical trauma isn't neatly confined to one specific layer of tissue.
Exactly. A surgeon often sees patients presenting with elongated inner tissue that causes them pain, while simultaneously, the outer tissue has completely deflated due to estrogen loss or aging.
So if you only treat one,
Right. If the surgeon only performs a labiaplasty to trim the inner tissue, the anatomical architecture remains unbalanced. The functional pain of the chafing is gone, but the structural deflation remains.
let's see if we can map this out for you guys listening. Doing a surgical labiaplasty is basically knocking down a wall to change the physical floor plan of your house. But adding the O-shot and the fillers,
That's upgrading the utility.
you're putting in new plumbing and rewiring the electrical system. Because the new floor plan is great, but if the internal sensation is numb and the tissue is dry-like, if the lights don't turn on and the water doesn't run, the house isn't actually livable.
The synergy of combining them is really powerful. The scalpel alters the physical architecture, while the O-shot is injected during the same session to boost the internal functionality.
It's a full package.
Clinics absolutely package this as a complete overhaul. You'll see marketing for things like the O concept, where they bundle the surgical excision, the PRP, the dermal fillers, and often even non-surgical laser treatments like the CO2RE Intima or Thermiva.
Wait, lasers. What are lasers doing inside this already incredibly complex combination procedure?
Well, those specific devices use thermal energy. They deliver controlled heat to the internal vaginal canal, which creates microscopic thermal injuries.
Ah, so it's the injury response again.
Just like the PRP. This tricks the body into a healing response, forcing it to produce tight, new collagen bands. It's an internal tightening mechanism paired with the external surgical restructuring.
But doing all of this simultaneously, surgical excision, liposuction for fat transfer, spinning blood for PRP, and internal laser burns, that has to result in a miserable extended recovery period, right? You're layering trauma on top of trauma.
You'd think so, but the physiological reality is surprisingly the opposite.
Really?
Yeah. The surgical labiaplasty is the rate-limiting step for recovery. It typically requires 6 weeks for the incisions to fully heal. The injectables and lasers, though, they have virtually zero downtime.
Oh, I see.
So layering the O-shot or fillers onto the surgery doesn't extend your recovery window by a single day. You heal from the minor interventions while you are already resting for the major one.
The medical mechanics are genuinely impressive. But zooming out, offering these massive multi-procedure designer packages requires a very high level of surgical precision, which leads to the massive red flag in our source material. Who is actually regulating these clinics to ensure the person holding the scalpel, the syringe, and the laser is qualified to do all three at once?
Right, the regulation aspect. The National Confidential Inquiry into Patient Outcome and Death (NCPOD) conducted a comprehensive organizational review of the cosmetic surgery sector.
And what did they find?
The environment they describe is alarmingly deregulated. They actually refer to it as a cottage industry.
Let's talk about the ghost clinics they found, because this detail is frankly terrifying. NCEPO attempted to survey the market just to see what safety protocols were in place. 11.5% of the surgical clinics they identified had completely vanished before the study could even contact them.
Almost 12% of facilities performing permanent, life-altering surgeries simply folded or relocated overnight.
Imagine being a patient who just had a multi-layered combination procedure. You develop a post-op infection, you go back to the clinic, and the doors are locked and the business is just gone.
It's a huge risk. And for the independent hospitals that remained open, the safety gaps are profound. 33% of the facilities performing cosmetic surgeries lacked a formalized anesthesia rota.
Wow.
Yeah, a third of them didn't have a guaranteed schedule of qualified anesthetists on duty.
The report also noted a severe lack of surgical repetition. When looking at complex cosmetic procedures, 79% of the clinics performed fewer than 20 of those operations a year.
In any other medical discipline, performing a complex surgery less than twice a month is considered unacceptable. Surgical proficiency requires constant repetition.
Of course it does.
Yet the NCPE report warns that the cosmetic sector is full of surgical teams who are perfectly willing to basically have a go at highly complex procedures they rarely perform.
And this lack of oversight collides directly with the ethical guidelines published by the NHS and the Royal College of Obstetricians and Gynecologists, because the NHS classifies these procedures as entirely non-essential. And the RCOG points out that there is a massive biological variation in what constitutes a normal vulva.
The ethical divide in the medical community regarding these surgeries is deep. On one side, you have medical ethicists and commentators who draw a direct parallel between cosmetic labiaplasty and female genital mutilation, or FGM.
That is an incredibly heavy comparison to make.
It is. It's based on the World Health Organization's strict definition. FGM includes any procedure that intentionally alters or injures female genital organs for non-medical reasons. So the critics argue that even when an adult woman fully consents, taking a scalpel to completely healthy, functional tissue simply to change its appearance, that fits the definition of mutilation for them.
But on the other hand, the proponents, the surgeons and the patients requesting these combinations, they reject that comparison entirely. They argue that bodily autonomy means an adult can consent to a labiaplasty the exact same way they consent to a breast augmentation or a rhinoplasty.
Right, and the proponents point to the outcome data to back up their stance. Multiple studies in our sources show post-operative satisfaction rates exceeding 90%.
90% is huge.
It is. Patients consistently report drastic improvements in their physical comfort, their sexual function, and their psychological well-being.
So the patients are generally happy with the results. But the NCEPO report reveals a disturbing lack of psychological vetting before they ever reach the operating table. Only 4% of the surveyed sites routinely used clinical psychologists to assess patients prior to surgery.
Which is concerning, because the RCG guidelines heavily stress that a patient's fixation on their genital appearance can sometimes be a displacement for deeper psychological anxieties or body dysmorphia.
Right. Treating the symptom instead of the cause.
Exactly. A clinical psychologist could identify if therapy, rather than a permanent surgery, is the appropriate treatment. But in a largely commercial, profit-driven market, that safety net simply doesn't exist at 96% of clinics.
So if you are exploring these options, you are walking into an environment where you are expected to be your own medical regulator. You are bombarded with slick marketing terms like designer vagina and promised a seamless combination of surgery and injectables.
The burden of safety falls almost entirely on your shoulders as the patient. The clinical evidence proves the synergy is real, right? You absolutely can combine a labiaplasty with labial fillers and the O-shot to safely rebuild both the architecture and the internal function of the tissue.
But getting that result requires you to aggressively vet the surgeon. You have to ask the uncomfortable questions. How many of these specific combinations do you actually perform a year? What is your protocol if something goes wrong? Are you treating a genuine physical symptom, or are you operating based on an anatomical insecurity created by internet aesthetics?
Navigating this space safely requires a high degree of anatomical literacy and a very healthy dose of skepticism toward the marketing.
Absolutely. And, as we step back from the clinical data, there's a fascinating broader shift happening here that's worth keeping an eye on. For decades, the absolute gold standard for altering the body had been the scalpel. If something bothered you, you physically cut it away.
The ultimate mechanical solution.
But look at the sheer power of the regenerative medicine we discussed today. Using a centrifuge to concentrate your own platelets, waking up your adult stem cells, forcing your body to literally grow new blood vessels and nerve endings from the inside out.
We are getting much, much better at commanding the body to heal itself.
Exactly. So as these regenerative therapies like the O-shot and stem cell transfers become increasingly advanced at restoring tissue vitality, resolving pain, and tightening structures without a single incision, will the desire to permanently slice away our own tissue eventually become a relic of the past? Decades from now, will we look back at the scalpel the way we look at medieval medicine, replaced entirely by the syringe? It's definitely something to think about.